Hello, everyone. Good afternoon. Good afternoon, Jen. I heard you all. The roar was amazing. Fabulous. All right, I hope you enjoyed your lunch. Welcome to this integrated coding and PDPM case study. This is going to take us for the next 2 hours. And it is my pleasure to be able to co-present this session with my friend and colleague, John Kane, who is a tough act to follow right after watching him all morning. Again, thanks to CMS and my colleagues at CMS and Econometrica for having me present. You will use several handouts today. They should be in the left side of your folder, or no, right side of your folder today, right? The handouts that you're going to need include the PDPM case study narrative, the integrated coding and PDPM case study coding sheet, the PDPM fact sheet and SNF classification walkthrough, and the integrated coding and PDPM case study HIPS information sheet. As in all of our sessions, we have a group of acronyms. Again, they're presented here. Again, I won't read this slide or the next to you, but I do want to remind you that you have that nice comprehensive acronym list in your folder. And here's our objectives. This session is your opportunity to apply all of the knowledge that you've acquired during this 2-day training and likely lots of other trainings and reading and all of that you've done before. And you'll use that knowledge to accurately code a clinical resident scenario, and you'll be able to calculate the appropriate health insurance prospective payment system or HIPS code under PDPM. So meet Mrs. S. She probably looks a lot like some other residents you've seen in these 2 days. She's a 78-year-old female. She was admitted to the acute care hospital on November 3rd with respiratory distress and right hip pain following a fall. Her admissions diagnoses were right proximal femoral fracture and exacerbation of congestive heart failure, or CHF. On the case study narrative, you'll see a bunch more information about her, and I'll share just a few more details about her with you. Her past medical history includes hypertension, CHF, COPD, and depression. She underwent a total hip arthroplasty on November 4th to repair her femoral fracture. She required post-op diuresis and supplemental oxygen due to her CHF. And during her hospitalization, she developed a stage 4 pressure ulcer on her coccyx. Her post-op status stabilized, but given her medical conditions and her continued need for pressure ulcer care, as well as OT and PT, she was transferred to your skilled nursing facility on December 1st. So as I mentioned, there is additional information in the case study narrative that you have in your folder. We'd like you now to work together, and I'm going to give you a little more info on this, but ultimately you're going to be using those 4 documents that I mentioned that are listed on this slide, and then use the case study to code a subset of the admission and discharge items on the coding sheet, and ultimately complete the PDPM calculation worksheet. You will also find information on your tables that you can share as a group. There's some additional resources. These are the items you're going to code for the 5-day. Again, I'm not going to read them to you. You can see them on the sheet itself. And then you'll also code the self-care and mobility items on the Part A PPS discharge. When you look at the coding sheet, you'll find some sections of the MDS already populated, and these are sections that you need in order to complete your calculation worksheet, but it's not necessarily info that's in your case study. The other thing I want to mention to you is you can assume that this resident, as I was looking at this, I thought, oh, there's one more piece of information I'm not sure if we gave you, but she had therapy, 1 discipline on the first Saturday she was there. Otherwise, she only had Monday through Friday therapy the next 3 weeks, okay? The rest of her stay. So you're going to need that piece of info to do some coding. Yep, she had therapy. I think it was OT on the first Saturday she was there. Then her therapy was scheduled Monday through Friday for both therapies, okay? So here's your charge for about the next half hour. Use the documents that I mentioned in the case study to go ahead and code that. John and I will, so actually I'll see you in about a half hour. We have planned 25 to 30 minutes. At the May training, folks needed a little more time to get through this, so I'm going to kind of check in with you around 25 or 30. I hope that the folks that are also participating remotely will take this opportunity to participate in this case study and come back. Plan on being back to debrief with us in a half hour, but know that we may give you a few more minutes at that time. So by my watch, it's 12:52, so somebody help keep me honest. I'll see you about 1:22, okay? We're around if we can help. And then after you guys complete this, I'll come back and debrief the coding with you before turning it over to John to walk through the calculations with you. Okay, so go forth and do. Holler if you have questions. And thanks again for sticking with us. You guys are doing great. All right, so let's start with Section A from our admission, our first assessment there. And how'd you code this? A0300 optional state assessment. No, right? Correct. And the rationale, again, this is our SNF-PPS assessment. How did you code A0310B? Did you code that as a 1, indicating a 5-day? Not much new here, except there's a whole lot less choices, right? Which is a good thing. And how did you code A0310E? Is this the first assessment since the most recent entry, admission, or reentry? Yes, and again, that is first, that's coded as 1, but in practice, again, we have just our PPS assessment here. Pretty likely in practice, you're going to be combining it with your OBRA assessment as well, right? And is this an SNF interrupted stay? No, and we heard about the interrupted stay. Just to review that, is when the resident is in a Part A stay, they're discharged from the SNF or discharged from Medicare Part A covered care or stay, they subsequently resume for that, within that interruption window. And when is that interruption window? How many days? 3 days, you got it. And our gender is what? Female, sure. And how'd you code A2400 Medicare stay? 1, excellent. And the start of Medicare? You're entering 12-1, super. And this end of Medicare, do you agree it's dashes? So I have a trivia question for you. We know that a dash is a standard no information code, but it also means that a date has not yet occurred. So in addition to this item, we use the dash for a date has not yet occurred in what other items? Therapy end dates. Woo, you guys are good. GG0100, prior functioning. Let's go on to this. Let's begin with looking at GG0100, prior functioning everyday activities. How did you code self-care, A? 3, sure, she lives with her son. She's in that 2-level home, and that prior to her acute hospitalization, she was independent. And that's what that says. And how about indoor mobility? I have a 3 as well, and again, we know that she used that rolling walker, but she was independent with that. And C, for stairs, how did she do? All right. I have a 2 that she needed some help. Great. And how about functional cognition? Oh, no. Yes, functional cognition. Oh, gave you the answer too. Clicker happy up here. So, and she did need some help with grocery shopping, paying the bills, doing things like that, her medication management. All right, and then we go on to prior device use. And prior device use captures that the devices and aids that she used immediately prior to her illness. And how'd you code this? A and D, great. Again, she used both of those. Your rationale is there. All right, next let's go on to GG0130, or self-care, with her admission performance and discharge goal. Remember that the coding is going to reflect the 3 days of her Part A stay, and the idea really is to capture the baseline before the resident has benefited from any physical therapy or occupational therapy or any therapy. So how'd you code eating? 5 and a 6, it sounds like. And again, here's the rationale for that. She does need some help with setup, opening containers, and cutting her food, but it's expected she'll be independent prior to her discharge. And then we have oral hygiene. 5 and 6, excellent. So the CNA again sets up her supplies, but the team expects she'll be independent with that. And then we have C, toileting hygiene. 4 on here. Again, in her OT evaluation, oops, that's oral hygiene. In her OT evaluation, we read that she needed some steadying assistance from her helper while she adjusts her underwear and slacks. So again, she is needing a little more help with this, supervision or touching assistance. And then we expect she'll be independent. Shower or bathe self? We have a 2 on this one, so needing much more help for this one. Again, substantial maximal help here. She is requiring more assistance. The helper helps her by wheeling in and provides her really with more than half the effort. So she is going to be coded a 2 there. And again, OT expects her to be independent, but perhaps with some adaptive equipment. Does that impact how we code her in this? Nope, right, adaptive equipment is fine. And next we have upper body dressing. Do you guys agree? Remember that upper body dressing can't be coded based on just a hospital gown, and my guess is nobody wears a hospital gown in most of your nursing homes, right, or facilities. Do they around the place? I want my jammies when I come to your nursing home, please, not a hospital gown. Don't want to be showing the back end to everybody walking by. All right, and again, she does need that setup or cleanup assistance. The CNA helps with her blouse and her bra, with getting those for her, and then she'll be independent. And then lower body dressing. How'd you do here? 3 and a 6, great. In OT, we have quite a bit of information about the help. We noticed that in the OT evaluation that she needed 1 helper, and she also did less than half the effort. And again, once we're seeing 2, right, we're coding different. If, again, somebody needed 2 helpers, probably not with lower body dressing, but perhaps. And then, again, she does half of the effort there. We expect that she will be able to dress independently by her discharge. And then finally, we have, for here, putting on and taking off therapy. How did you guys decide on that? So the 1 right now, that's correct. Dependent for admission, 6 for in discharge goal. And there's our rationale. 1 helper does this for her, puts on her socks and shoes for her, but we do expect that she'll be independent. All right, let's go on to GG0170. Here we're looking at mobility, admission, performance, and discharge. And like the section we just looked at, this is a 3-day assessment window, hopefully capturing the status prior to the benefit of any therapy. Now there's an alarm again. What is with you guys, an alarm when I'm speaking? Do you need that to stay awake? What is it? Is it this? All right, anyway, so first we come to GG0170A, roll left and right. For coding on this, we looked to our PT notes and our case study, and what did you find out here? Coded as a 2. Excellent. And we hope that she'll be a 6 on discharge. And here's her rationale. The therapist provided more than half the effort, but it expects that by discharge, she'll be independent with bed mobility, including left to right. And then sit to lying. Again, we have a 2. And the PT, again, notes that she only contributed a small amount. So the resident only contributed a small amount. So again, we have a code of 2. And as I mentioned, here's our rationale. Again, therapy provided more than half the effort, but the therapist expects she'll be independent. So next we have lying to sitting on the side of the bed. And before we look at the coding for this item, I think that it's important to note that there are coding tips for the items that we just reviewed, just a couple of them. However, there's 5 tips for this item. And why do I mention that? Because so often it's the coding tips that really guide the assessors. And often it's the tips that provide the answers to the questions that get submitted to the RA coordinator or to the CMS help desk. So I just encourage you, when you're reviewing the RAI manual and as you're training folks on the manual, that you apply those coding tips to various scenarios. Most of the time, coding tips are added in response to multiple questions about a particular thing. So they really are a very, very important part of the instructions. So let's take a look at how we coded this. We have a 2 and a 6. Do you agree? Great. Again, quite a bit of information to support coding her admission performance as 0-2. We note that she can bring her left leg off the bed, assist with pushing up, and then needs assistance to bring that other leg off the side of the bed and is fully supported to come to that sitting position. And I think we'd agree on that it's more than half the effort based on that. But we expect she'll be independent when she goes. And then we have sit to stand, or GG0170D. I hear again a 2, and again our case study indicates that she does require maximal assistance. But PT therapist uses a gait belt, Mrs. S can steady herself, but the PT expects that she'll be independent with her rolling walker when she leaves. And then chair to bed transfer. Like the other items here, we've coded that a 2 and a 6. And again, our therapist noted that she required that maximal assist to pivot transfer to a wheelchair. The therapist provides more than half the effort, and the therapist expects that she'll conduct that independently when she leaves with her walker. And then we have toilet transfer. And here we change it up a little bit, and we have a 3 and a 6. Do you guys agree? Yeah. So partial or moderate, and that is our staff member, our helper, is doing less than half. So we go back to OT's notes to code here, and in those notes we see she required the assistance of one helper to slowly lower her with trunk support onto her bedside, and provides contact guard when she gets off the commode, and again the helper provides less than half the effort. And then car transfer. 8, 8, and a 4, great. Keep in mind we have those 4 activity did not occur codes. We have that they could refuse. It's not applicable because there wasn't attempted and the individual didn't perform that prior to their current illness, exacerbation, or injury. A 10 if it was environmental limitations, or not attempted due to medical concerns or medical condition or safety concerns, which is the case for our resident. And again, our rationale, this just was not tried on admission, but they expect with a contact guard and her walker, she'll be able to do this activity prior to her discharge. Let's look at walk. How did you code walk? 10 feet. 3, 4, great, you guys are good. Let's look at the rationale. There she does walk 10 feet with a walker and assistance of one helper. She needs steadying help, and she really needs some of her weight to be supported in the last 3 of those 10 feet. And by discharge, it's expected that she'll be able to do this using her walker with supervision or touching. Walk 50 feet with 2 turns. I have 8-8, I agree, and then 0-4. And again, let's look at the rationale. This was not attempted due to her fatigue and decreased endurance. Any distance beyond 15 feet for her requires that manual wheelchair, but they do expect that she'll be able to do this with contact guard when she leaves the facility using her rollator walker. And how did you code walk 50 feet? 0909, great. And again, she wasn't doing this before, and it's not expected she'll do this after her SNF stay. Okay. All righty, and walking 10 feet on uneven surfaces. How'd she do with that? I have 8-8, but it's expected to be that she'll, by discharge, will be able to do this with one helper with supervision or touching. And again, due to her medical condition, it wasn't tried, but we expect she'll be able to do that with her walker and the help. And then a curb. I have 8-8. Then what happens when we code 8-8? What do we do then? So we code 8-8, not attempted due to medical condition. And then what happens? A skip pattern, right? We skip all the way to what? GG 170P. So we know if we can't attempt one, we can't attempt the rest of them, right? All right, and here again, picking up the object is not attempted due to the medical condition, but we expect that she'll be able to do this with setup when she leaves. Do you agree? Great. And she will, again, require adaptive equipment, right? She can't bend at the hip. Is that okay? Can she use a reacher or whatever? Sure. And next we get to, does she use a wheelchair or scooter? How would you code this one? Oh, this is one of those clicker questions to make sure you're awake. So if you would, please go ahead and use Slido. Take just a moment to pick yes or no to indicate whether she uses a wheelchair or scooter. And we'll give just another minute for our folks online as well as those in the room who are just waking Slido up. Okay, it looks like we're almost all yes. Let's see what the right answer is. Yes, it is. Anything more than 15 feet, we know she needs a wheelchair. So how did she do with wheeling 50 feet with 2 turns? I have a 2 and a 6. Do you guys agree? Great. For her admission performance, the rationale is once she is seated in her wheelchair, she could complete those 2 turns, but she can only propel about 20 feet, and someone needs to help her for the last 30 feet because of her poor endurance. And remember, with that, they expect she'll be able to do that without any help at discharge. Remember, those 2 turns can be same way, different directions, and they have to be how many degrees? 90 degrees, right? And then indicate the type of wheelchair or scooter. Again, you go to Slido for this. Was it manual or was it motorized? So you indicate the type of the wheelchair. A for manual and B for motorized. And we'll give just a moment for that. Okay, let's see what we came up with. And again, it is manual. She used a manual wheelchair. And then we have wheel 150 feet. Okay, we have 0202. Great. And again, on admission, she becomes fatigued after only about 20 feet. The therapist needs to help her. And they believe that she'll probably only go about 60 feet when she reaches her maximum potential, and that someone will need to help her with the rest. Remember, she did only go about 70 feet prior to her injury. All right, and there's our rationale for that. Again, we're going to return to polling to indicate what type of wheelchair we used for her. Going that longer distance, did she use a manual wheelchair or a motorized wheelchair? Okay, looks like almost everybody said manual. And that is correct. And here's our last screenshot of section GG that shows that, GG 170. And we're going to move on to I0020, the resident's primary medical condition. So here's a screenshot of I0020. Remember, in this item, the assessor documents the resident's primary medical condition category that best describes the primary reason for the Part A stay. And I want to give you all a secret. All of you that send the questions to say, what is the primary reason for their medical stay? We are not at the bedside. Who knows that information? The caregivers. Who can help them if they can't figure it out? John? The physician, right, who's admitting them and saying why they need medical care. Okay? We do not know everybody hear that? Tell your friends. Shout it from the lighthouse. We do not know the primary reason for their medical care. Y'all got that? Excellent. Okay? John, how many questions do you have after we say that from this group? No. But really, guys, think about clinical judgment, all of what you know about your residents. We can't tell that from 1,000 miles away. You guys are at that bedside, caring for the people. You know what's going on with those individuals. That makes sense? And sometimes it might be, you can't say, well, that patient came in with this, they have this issue. And this guy has the same issue, they must have the same condition. It's all about using the guidance in the manual, asking the physician, getting that information. So, with that, what is Mrs. S's primary medical condition category? Is it hip and knee fracture, fractures and other multiple trauma, debility or cardiorespiratory conditions, or medically complex conditions? And go ahead and just take a couple of minutes and vote on that. You guys have been great with participating in the case studies and the pollings and all of that. We hope it keeps you awake and moving ahead with us, so thanks for doing that. All right, I think we're almost up about 300 or so. Let's look at what the right answer is. It is fractures and other multiple trauma. And remember, if it's a resident's primary medical condition is fractures or other multiple trauma, it includes hip fractures, pelvic fractures, other fractures as well, okay? All right, and there's our rationale. And what we have here is why we wouldn't code them. So we're not doing the replacement, coding the replacement, because even though she had that, it was secondary to her fracture. And she also does have CHF and COPD, but that's not the primary reason she's in your facility. And she doesn't, again, she has her pressure ulcer that may be considered a medically complex condition, but that's not what prompted her to come to your SNF. Does that make sense? Great. And here's the ICD-9 code again. So we're coding that for a 10. And there's your ICD-9 code. Again, this is, you guys go back to the physician to say, what is going on here? What are we coding? And then looking up, finding those codes. And then also in this, we are going to, so the code she has here, again, it's the fracture of an unspecified part of the neck of the right femur. a subsequent encounter with a closed fracture with routine healing, so that's the level of detail here with the ICD-10. And you'd also check I-3900 for this as well for her diagnoses. And that is right there, okay? Great. Prior surgery. You all ready? Did she have prior surgery? Yes. So remember, we're talking about major surgery in the last 100 days prior to her admission. And remember that major surgery for this item, for J2000, refers to a procedure, generally refers to a procedure that meets the following criteria. The resident was an inpatient in acute care for at least 1 day in the 100 days prior to admission to the SNF, and the surgery carried some degree of risk to the resident's life and potentially severe disability. If you're not sure of that, who can help you? The provider, absolutely. The physicians, get some input if you're not sure and not confident to make that decision. Again, one case for one resident may be very different from another. And then recent surgery requiring active SNF, yes. And again, she had that major, that hip surgery following her fracture and then ends up in your SNF. Then we look at the surgical procedures. This is just kind of a snapshot, a subset of those items. And here are the assessor code surgeries that have happened within the last 30 days and during the inpatient stay immediately preceding that SNF Part A admission, and that have a direct relationship to that SNF diagnosis that's coded in I0020B. So what did you check here? Hip replacement. And we know that she had that hip replacement in the last 30 days, right before she came to the SNF, and that is a direct relationship. Remember, you're not going to code conditions here that have been resolved, that do not affect the current status or do not drive that resident's plan of care, as these would be considered surgeries that do not require active care in the skilled nursing facility. And that does it for the 5-day assessment. Let's move on to the discharge assessment. Oh, I'm sorry, there's our rationale again with the surgery. So, self-care discharge performance. I assure you this part's going to go pretty quick. So, then we'll get John up here. So we have eating. Everybody agree, independent? Yep. So she could do all her own setup. She used her utensils, and she could use a glass or a cup to feed herself and to drink her liquids. Oral hygiene, we have 6 as well. Again, she could do all of her hygiene tasks, brushing her teeth without any help. And toileting hygiene, 6, yep. Again, she was independent with her perineal hygiene and her clothing adjustment, didn't need any help with that. And shower or bathe self, also 6. With this, she was independent when she used her chair and other adaptive equipment, and that's just fine that she used that. And then upper body dressing, again, a 6, she's independent there. And lower body dressing, 6 as well, still independent there. And how about her footwear? 6 as well, great. Again, she could do her socks and shoes independently, use some adaptive equipment, and that's just fine for section GG. And then we go to her mobility performance at discharge, rolling left to right, 6. Again, she could do that side to side, back onto her back without any help. With her bed, sitting to lying, again, independent with that. Could go from sitting to supine, and from lying to sitting on the edge of the bed. She was also independent, so she really could move around from sitting to lying and moving around in bed without any trouble. Then we have sit to stand. 6 as well, so she could go from a seated to a standing position using her walker, but not requiring any help. And then chair, bed to chair transfer. Again, a 6, she could use her walker, but could do that independently. Her toilet transfer, again, a 6. She could get on and off that toilet without any help. She used a raised toilet seat, but that's just fine. And then the car transfer, how'd she do with that? 0-4, excellent. Again, at discharge, she performs those with just contact guard. What if someone just had to supervise her? How would she be coded then? 4, right. Remember, contact guard or touching assistance, 4, good. And then walk 10 feet, we had 4 as well. And again, there she's using, that is that scenario, she's using just supervision, having just supervision. How about walk 50 feet with 2 turns? 4 as well. Again, she could do that with her walker and that contact guard help. And then walk 150 feet. 9, she wasn't doing that before and she's still not doing that. Great. All right, then we go to walking on uneven surfaces. I have a 4, and I heard some 4s from the audience. That's great. Again, she needed contact guard with that. How about steps? Could she do 1 step? She needed, I hear a 4, and she needed some contact guard. Do you agree? Yeah, 1 helper. Excuse me. How about 4 steps? Also a 4. Great. Again, contact guard of 1 helper. And how about 12 steps? 0-4 again. And you guys are right on with that. Again, contact guard. And she lived on the 2nd floor, I believe, so I'm glad we got her going 12 steps. And then how about picking up an object? 0-5. Great. And our rationale for that, she needed her setup of her adaptive equipment, but after that she was just fine to do that. And does she use a wheelchair or a scooter? Right back to that Slido. So does she use a wheelchair or a scooter? Select A for no and B for yes. And we'll give just a couple of moments for you to get your answers in. Okay, let's see how we did. Excellent. We have yes, used a manual wheelchair. And so could she wheel 50 feet with 2 turns? Yep. Do you agree with a 6 on that one? Great. So she was able to go about 60 feet with 2 turns without any help. And how about wheel 150 feet? Oh, I'm sorry, we need to indicate what type of wheelchair. Sorry. Again, back to Slido to indicate manual or motorized. And I'll give you just a moment to do that. You guys are still participating pretty robustly. You've stuck with us for 2 long days. Great job. All right, let's see how we came out for an answer. Manual is correct. She used her manual wheelchair. And how about, oh, we've got our wheeling 150 feet. I have 0-2. And she could go about 60 feet, but the helper needs to help her with that remaining 90 feet. Great. And again, indicate the type of wheelchair that was used. And you'll pick A for manual and B for motorized. And we'll give you just another moment there. All right, let's see how we did. Great, manual. Again, she did use a manual wheelchair. So that does it for GG. There was our last screenshot of GG, and let's move on to look at 00425, Part A therapies. I'm just going to really quickly review this because the coding is already populated here. So on this, she didn't receive any speech, so we are skipping those. She did have 16 OT sessions, and that totaled 908 minutes, and she had 72 individual, 70 concurrent, 106 group, and 47 co-treatment sessions. And then for physical therapy, again, she had a total of 635 minutes of individual, total of 825 altogether, 635 individual, 40 concurrent, 100 group, and 63 co-treatment for 15 days. And when we look at distinct calendar days, this is the last item I'll debrief with you. How many distinct days did she have? Remember I gave you a little hint on that one? She did have 16 days when she received at least 15 minutes of therapy. She had OT on that first Saturday, but then the rest of her therapy was Monday through Friday. And at this point, I'm going to turn this presentation over to John, and thank you guys for your time and attention this afternoon. Appreciate it.
Okay, so I have Jen's phone number for all of you to just call her with questions, so you know. Unless your building is in Hawaii, in which case I'd be happy to fly out there, meet with you personally, it's no problem. All right, so with all the information that Jen just went through, we're now going to walk through how this patient would actually get classified under PDPM, given all the information that we just did. So the first step we have is in terms of the calculation of the PDPM cognitive level, which is relevant in terms of the SLP component under PDPM. This is where we're going to derive from the BIMS or the staff assessment. Now, there is something on this slide that is incorrect, and I will apologize for that. This is something that I should have caught. The second bullet here, where it says, if neither the BIMS nor the staff assessment is completed, then they cannot be assigned, and therefore a PDPM case mix group cannot be determined. This is no longer the case. Okay, we had heard you very loud and clear about the problems associated with this, and so we actually were able to make a change in the grouper for this, where if neither the BIMS nor the staff assessment is completed, then the patient will simply be characterized as being cognitively intact. So what that ultimately means for you is that if the person, let's just say you were going through the SLP, sorry? Okay. So let's say we were going through the SLP component and you get to that first criteria where it was presence of an acute neurologic condition, SLP-related comorbidity, or cognitive impairment. It would mean that for that third one, cognitive impairment, you just wouldn't be able to get credit for that if the BIMS or staff assessment weren't completed. But if the person had an acute neurologic condition and a speech-related comorbidity, and the BIMS and the staff assessment weren't done, you'd still get the NE2 for that one. So that is a pretty significant change from what is listed in the second bullet, which should hopefully allay some concerns around that. So the first step is in terms of determining the BIMS score. So step one, we determine the BIMS score as recorded in MDS item C0500. And the BIMS summary score here was 14. Hopefully everyone has that. Determine the resident's PDPM cognitive level based on that BIMS score. So the person had a score of 14, and so that would put them in the 13 to 15 bin, and therefore they are identified as being cognitively intact. Step two, if the BIMS score is blank or has a dash value, you go to the staff assessment. Here, that was not necessary because we did have a BIMS score, and that score was a 14, which again was cognitively intact. The next step is in terms of the PT component, and where we start is with the clinical category, and that starts with the primary diagnosis that is coded in I-20B. So here, Jen already went through this in terms of the code, which was 10, and then the actual ICD-10 code, which was the S72.001D code. That code maps to the major joint replacement or spinal surgery group. If you look in our ICD-10 mapping that's available on the PDPM website. And so we have that again maps to this clinical category. The default clinical category here, again, is the major joint replacement or spinal surgery group based on that ICD-10 code. Go to step 1A, which is determine if they received a major joint replacement or spinal surgery as coded in section J, specifically J2100. And here the answer is Yes, they did. So you would code 1. Okay. Step 1B and 1C speak to if the resident would be eligible for the surgical clinical category and received orthopedic surgery except MJR or spinal surgery. 1C is if they're eligible for the surgical clinical category and received a significant non-orthopedic surgical procedure. This is where we talk about the interplay between the Section J surgery checkoffs and the clinical category, because there are some, say, orthopedic conditions where they have a surgical procedure that may be done as well as a non-surgical intervention. And here, if you might get the default non-surgical category, but if we see that surgery is checked off in Section J, you get the surgery categories associated with that. Here, however, there was a major joint replacement that was done, and therefore neither 1B nor 1C applies here, and so both of the responses here is no. If any of the procedures in J2300 through J2420 was performed during the prior inpatient stay, then the resident is categorized into the MGR or spinal surgery group. We did have one. Which one was it? 2310, hip replacement. So based on the responses in J2100 and 2310, is Mrs. S eligible for the surgical clinical category and received major joint replacement or spinal surgery? And we will now move to there we go. That was probably my fault it didn't come up. So lots of yeses, 2 nos. Come on, nos, you can do it. Lots of yeses, lots of yeses. One more no, or one no got away. Oh. One's holding out. Come on. All right. Despite the underdog, I apologize to the one person who said no. We'll go back to the question and find the answer. And the answer was yes. Kind of wish there was a no, just because that one person stood out and would laugh at everyone. But the answer is yes. They did have the prior surgery. It was the major joint replacement, which is checked off in 2310, as we just saw on the prior slide. Next step in terms of determining the resident's primary diagnosis and clinical category is that, as you saw earlier in my presentation, there was those collapsed clinical categories. So we had the default clinical categories, of which there were 10. Those collapsed down into 4 clinical categories, of which MJR or spinal surgery is one of them. And so therefore, they would fall into that as the primary diagnosis clinical category for their PT component. So step 1D, finalize the assignment. If they're not eligible for a different clinical category from the default, you select the one that they fell into. Here, that was the major joint replacement spinal surgery group, and therefore that is the patient's primary diagnosis clinical category. Step 2, we're now on to step 2, taking us a long time to get here. So step 2, we look at this, the mapping again in terms of collapsing the clinical categories together. MJR actually translates directly back over into the major joint replacement spinal surgery group. And so because they were in the major joint replacement spinal surgery group as the default category, they then go, their PT clinical category is also the same MJR group. Next step, now that we're beyond the clinical category, is to actually look at their functional score. So here, again, Jen did a great job of walking through all the section GG coding. Here, all we're going to do is say that based on that coding, here's what their functional score would be. So this is the same slide you saw earlier as far as what scores they received for their admission performance, and this is just going to show the translation from that admission performance score over to what their actual scores would be under section GG. So here, as you can see, if they had a 0.5 or 0.6, it translates to a 4. A 0.4 in the admission performance translates to a 3, so on and so forth. So here, again, you can see for the mobility admission performance for G0170, again, you can see the scores that were provided for each of those, and then the mapping is to the right that shows what those scores translate to in terms of their functional score. So now we can see how each of those translates over, and we can start to see what the patient's total functional score would be. So for eating, it was an 0.5, and therefore that translates to a 4. Oral hygiene, it was an 0.5, translates to a 4, so on and so forth for each one of these. You can, again, this is just taking the performance score and mapping it to its correlated functional score. The next step is to average the function scores for the 2 bed mobility items, the 3 transfer items, and the 2 walking items. And so for the bed mobility, you would take the sum of the function scores from sit to lying and lying to sitting on the bed, divide that sum by 2. So each of those had a 1, so you have 1 plus 1 equals 2. Divide that by 2, you get back to a bed mobility function score of the average of 1. Average transfer, taking the sum again of these 3, which is sit to stand, chair, bed to chair, and toilet transfer. So each of those was a 1, and a 2 respectively. That adds up to a 4. You divide that by 4 to get the average. The average is 1.3, and we're going to leave it as 1.3 for the moment. Same for walking. Again, taking the average of the walking 50 feet with 2 turns as well as the walking 150 feet. Add those together, they were both 0. 0 divided by 2, we're left with 0. You now calculate the sum of all of those, okay, that were listed here, the eating, the oral hygiene, toileting hygiene, and then the averages from those 3 that we just did. Take all those together, you get to 13.3. So again, you keep that decimal through to this point. You then, once you get to the end, round to the nearest whole number. Okay, and once you round to the whole number, that's 13. PT function score is 13. Okay, everyone get 13? Anyone have, well, for questions about that, I think we'll take that later. PT case mix group. So now that we have their PT clinical category as well as their functional score, we can actually now figure out what group they fall into. And so they had a major joint replacement spinal surgery clinical category. Their functional score was a 13. And so based on steps 1 and 2, in terms of where this person fell, they would then fall into the group TC. Okay, so as the MJR, okay, their functional score puts them in the 10 to 23 bin. That translates to a case mix group of TC. OT, really simple. If they're in PT group TC, they're in OT group TC. Super simple, that's pretty much it. Moving on to SLP. For SLP, very different classification methodology than we saw for PT and OT. So it starts off, though, in the same way, which is to look at the clinical category. And again, the clinical category was the major joint replacement or spinal surgery group. In terms of that mapping, that collapse mapping from the clinical category to the component-specific clinical category, here we see that major joint replacement maps to the non-neurologic category. Okay, which really just means they don't have an acute neurologic issue. If it's not acute neurologic, they go into the non-neurologic group. The next step is to determine if there are any SLP-related comorbidities. And Mrs. S does not have any of these comorbidities that would be coded in section I or O on the 5-day assessment, and so we leave this one behind. The next was to determine the presence of a cognitive impairment. We had done that with the BIMS score earlier, set a score of 14, which identified Mrs. S as being cognitively intact, and therefore that means there is no presence of a cognitive impairment. Step 5, you determine how many of the following conditions are present. There were those 3 criteria that I mentioned earlier: acute neurologic condition, SLP-related comorbidity, or cognitive impairment. Mrs. S did not have any of these on the 5-day, and therefore the number of conditions present is equal to 0. So then we move on to the next set of criteria, which were swallowing disorder and mechanically altered diet. So for the first one, in terms of a swallowing disorder, we use K0-100, and we see that Mrs. S did not have any signs or symptoms of a possible swallowing disorder. Step 7, we look to see whether or not Mrs. S was on a mechanically altered diet, and as we see here, as checked off in KO510C, that Mrs. S was on a mechanically altered diet. So now we go to step 8, which is to look at those 2 criteria in concert with each other to determine whether or not neither of them were present, either of them was present, or if they were both present. Here we see that even though Mrs. S does not have a swallowing disorder, she was on a mechanically altered diet, and therefore she would qualify for either. We go on to step 9, which is to take those 2 sets of criteria together. For the first one, it was that there was no presence of an acute neurologic condition, comorbidity, or cognitive impairment, and then there was a mechanically altered diet, so she went into the either. And so ultimately, Mrs. S goes into group SB. So we've now gotten through the therapy components for Mrs. S's classification. Next one we're going to move on to is the non-therapy ancillary component. Here, as I mentioned earlier, today there's the NTA comorbidity score. That's how we identify a person's NTA component rate. So here we look to see if the patient qualified for any of the various NTA comorbidities that we have listed. Here we found that there was actually one condition for which Mrs. S, or the Mrs. S had that qualified for the NTA component, and that was the presence of a stage 4 pressure ulcer, which was coded in M0300D1. That ulcer counts for 1 point, and therefore Mrs. S's comorbidity score is a score of 1. So the COPD was listed as something that was in her history, but not listed as being active, and therefore it wouldn't.
Fatigue and endurance issues during therapy.
Right, but unless the active diagnosis is coded on the MDS, which in this case study it was not, then the patient wouldn't classify for that, and therefore it wouldn't count toward their NTA comorbidity score. So all of it depends on if that item is checked off on the MDS as being an active diagnosis. I can't remember which item it is. I think it's I-6200, something like that.
So it was an MDS coding error.
Whether it was a coding error, I will leave aside and probably turn to the table over there. But in so much as it is not coded on the MDS, then the grouper wouldn't give credit for it, and therefore it's a score of 1. So determine the resident's NTA group based on their classification. Here they had a score of 1, and therefore they fit into the group 1 to 2. If COPD were coded, just to throw that out there, I think COPD counts for 2 points. That would give them a total score of 3, which would put them into the ND group. So just if you happen to have coded that, that's the group they would have been in with the COPD. But here, we're going to say they're in group NE. Last step in terms of overall components is the calculation of the PDPM nursing function score, okay, or the nursing component. So first we begin with the nursing function score, which is distinct from the therapy score. So just be aware that the things that we use for calculating the nursing function score are different than those that we use for the therapy score. So the mapping is basically the same in terms of the score within the admission or interim performance versus what it codes out to in terms of the function score. So here, again, we're going to see just the same GG coding that we saw earlier that Jen already went over. And it just shows what that score, and the ones that are relevant are highlighted in yellow or green. I'm colorblind, so I don't know. But some color that's there. And it maps over to a function score. Same for the mobility items. Again, those are highlighted in that color. And then maps over. So here we actually have listed out all of the various ones that we use for the nursing function score and what they translate to in terms of the admission score versus the function score that we use for the calculation of their group. Next step is to average the 2 bed mobility items and the 3 transfer items, same as we did earlier. Here, bed mobility, again, it was a 1 and a 1, sums to 2. 2 divided by 2, you get to an average score of 1. Same for transfer, is the same exact calculation we did earlier. 1 plus 1 plus 2 to 4. 4 divided by 3, you get to 1.3. Maintain the decimal at this point. You now calculate the sum of adding those averages that we just calculated back to the eating and toileting hygiene, okay, which were 4 and 3. You get a total score of 9.3, then round that off to the nearest whole number, which is 9, and their PDPM nursing function score is a 9. Next is to determine the resident's nursing case mix group, which, as I mentioned earlier, is basically the same as how you would do it currently. So it's the exact same steps that we get to in order to identify their nursing group as we do under RUG 4. So first, to determine which of these 6 categories they're going to fall into, the extensive services through the reduced physical function. And the assigned classification is the first group for which the resident is qualified. So the first one we look at, extensive services. So determine whether or not any of these extensive services were coded while a resident. And for Mrs. S, none of those services were received while a resident. So therefore, not extensive services. Next step is special care high. We see whether or not any of those treatments and services that were identified under special care high were received. None of those were received while she was a resident, and therefore, not special care high. We move to special care low, determine whether or not any of these conditions or services that are listed were checked off, and if not, you skip to clinically complex. Mrs. S, however, does have one of the listed conditions that was from the selected treatments, and that was the stage 4 M0300D1 pressure ulcer, 2 or more skin treatments, and so therefore she would qualify for special care low. Step 2, if at least one of the special care conditions is coded and the resident has a total PDPM function score of 14 or less, which she does, having a function score of 9, she qualifies for special care low. And so here, based on the coding on the MDS, we see that Mrs. S qualifies for special care low. We do not need to consider the clinically complex or reduced physical function. we have her nursing category at this point. The next step is that this category happens to come with an end split for depression, and so we evaluate the patient for the presence of depression. And we look to see whether or not the total severity score that's listed in item D0300 is equal to 10 or greater, okay, but not 99. And we look here, and the total severity score for Mrs. S was a 2, as in this is listed in D0300, and therefore Mrs. S does not qualify for the depression end split for this category. Step 4, pulling all these various factors together. We have the special care low classification, function score of 9, and the absence of depression. And therefore, putting all of those things together, Mrs. S would qualify for LBC1. Now the HIPS code. So now that we have all this information, okay, we have all the various case mix components done. Okay, the last thing we'll talk about is the AI indicator. But in order to build the HIPS code, if you remember before, it basically gets built on each of those individual components. So for the first one, Mrs. S was classified into group TC. Basically just carve off the T. The first character in the HIPS code is a C. The second character is the SLP component. Based on all the various criteria, Mrs. S qualified for group SB. Again, carve off the first letter. The character for the HIPS code is a B. Nursing component, again, special care low and function score of 9 with no symptoms of depression, qualified for group LBC1. This is where you actually do have to look at the mapping to see how it translates over. And here, LBC1 translates to a K for the character within the HIPS code. Fourth component, which is the NTA component, has, again, NTA score of 1 or 3, depending on how you coded it, but we'll go with 1 for now. So if it was a 1, group was NE, again, carve off the N, you get the E. The E is the character you use in the HIPS code. If it was C, you'd use a C. The last part of it is the assessment indicator. There are only 2 as compared to all the ones compared to all the ones we have under RUG 4. We only have the 2. It's either a 5-day or it's an interim payment assessment. Here, we're talking about a 5-day PPS assessment, and therefore the 5th HIPS character, which is the assessment indicator, would be a 1. Put all of those 5 things together, you get to this HIPS code, okay, which could be CBKE1 or C1, depending on the COPD. But here, we have CBKE1 as the HIPS code for this person. So we've done the case study, and if you have any questions about that, please submit them to Slido, and we'll go over them. And thank you all for participating in this. So we have like 12 minutes left, apparently. So I don't have anything else to do, so why not take some live Q&A? So if you guys have some questions, you want to throw them out there? We'll just kind of ad hoc it a little bit. Oh, we have some Slido questions. Okay, I'll take a couple of these while you guys think of questions. So the first one was, how come there are therapy items on the 5-day NP item set if therapy day and minutes will not go into calculating the PDPM code? And how come if they are needed on the 5-day set, they are not needed for the IPA item set? That second question is actually, that's a really, really good question. I'll have to think more about why we didn't put it on the IPA. The reason, though, that we wanted to maintain the therapy items on the 5-day assessment was because we wanted to be able to see in that first week what was happening in terms of their therapy, particularly for data monitoring purposes. We wanted to see what is happening in that first week currently under RUG 4, and then what is happening on that 5-day in that first week under PDPM. So a lot of that was just for us to be able to monitor what was going on during that first week. As far as why we didn't include it on the IPA item set, that's a really good question. I probably would have personally preferred to have it on there just to kind of see what's happening at that point. So that's something we can potentially look at. Questions are changing all over the place. Is just therapy documentation enough to code section GG? That I cannot answer. I'll have to turn to one of my colleagues to answer that one. Jen, I don't know if you want to throw out an answer on that.
No, I do not.
Okay, fair enough. Does the primary diagnosis in
I am not a
I-20B have to match the primary diagnosis that is billed on the UBO4? This is a great question. And the answer is no, but. So the technical answer is no, they don't need to match. However, my question back to that would be, why don't they? And so do they have to match in order for you to actually get paid? No, you will get paid based on the HIPS code that is reported on the claim, not based on the primary diagnosis that is listed on the claim. However, that would be something that I would look at and say, I wonder why these two things are not matching. And the last one that's here is, in working through the case study, it's interesting that all information is therapy-based when this is to be collaborative between therapy and nursing as per RAI manual guidance.
John,
I'm
you
not
want to
sure.
take some from the crowd?
Sure, because I'm actually not sure that that one's
Where was
true.
my person who was running after me?
Well, it's just a quick question. On your slides, you had the AIDS add-on to the nursing component still at 18%, but in the final rule, it had 12.8%.
It did?
Is that a typo? Yeah, it does.
I'd have to look at that. That's odd.
I know, because it says 128 goes to 12.8, so, because I went back into the final rule and double-checked myself.
Yeah, I'll take a look at that. That is, if it is, that's definitely a typo. It's
Question?
the current adjustment is 128% on the entire per diem, and under PDPM, it's an 18% add-on for nursing, and then there's the NTA component of it. So yeah, I'll take a look at that. That's weird. Thank you.
I just have a question about the transition
Sure.
for the IPA. What's the start date in the 2400 for Medicare? Would it be the date from September?
It would be the date that they started their Medicare stay.
Okay.
Correct. Oh, sorry. I apologize. The question was on those transitional IPAs, what date should be coded into A2400 for the Medicare start date? And the answer was that it should be when they started on their Medicare stay. Sorry, I apologize.
Who's next?
No other questions, really? Oh, no, we do have questions. Right?
I'm gonna have this gal ask her question. We'll get over to you.
Sorry.
Yep. I have a question in regards to the calculation you just took us through. When you brought up the crosswalk for the ICD-10 code, when it got to that clinical category on your slide, it said the major joint replacement. But on the actual crosswalk, it says non-surgical for that diagnosis.
It does?
So I'm totally thrown off on how you got to major joint using the crosswalk. And I know the surgery that says may be eligible based on the surgery, but I just pulled it up off the website.
Okay, that might be a typo on the slide, but because of the checkoff in the MJR in section J, you're going to end up in the MJR regardless.
You'll get there regardless,
Yeah.
just because I said they had, because when I
Yes.
get to the surgeries, then I wouldn't mark that they actually had a fracture repair. I would still say hip replacement, even though it was
Yeah.
related to the fall, not a planned hip replacement.
No, but as long as they had a hip replacement that's documented, then you can code the hip replacement, and then that would put them into the MJR group.
Okay.
Kathy, go ahead.
Hello. This is a follow-up to the primary diagnosis question that's on the screen. Correct ICD-10 coding in, for example, the sepsis case that we had earlier in the slides. The patient had a procedure complication infection that led to the sepsis, which is a T code in ICD-10. And then a secondary code would have been the A code that you listed as the code that would go into the I-20B. Are you indicating that that particular box is not meant to be always the same as what the principal diagnosis would be on the UB, because we would focus on the infection itself, like the staph infection itself, rather than the fact that the staph infection was from a complication? So the complication code would not be the reason for the admission, but it would be the principal diagnosis on our UB.
Okay, so, I mean, part of this could be my misapprehension of what the principal diagnosis on the UB is intended to reflect, in so much as, so I mean, I-20B is intended to reflect the primary reason that they were admitted for the SNF stay. So personally, I mean, I would think of that as being the principal diagnosis, but to the extent that that box on the UB is being used for a different purpose, then again, I could see why they wouldn't match. But the main thing that I would want to indicate to folks is that regardless of any mismatch, they're still going to receive payment based on the HIPS code that is presented on the claim, regardless of discordance between the two diagnoses.
Because some codes do require that there be a code listed before it. Whenever we're coding, we have sequencing guidelines.
Mm-hmm.
So if our sequencing guidelines, according to the ICD-10 CM guidelines and conventions, say that we would code the complication first and we would code the staph infection second.
Okay.
Your example has the staph infection listed in the I-20B space, but the UB, if it's coded and sequenced correctly, would have the complication code listed first.
Got it.
And the infection code listed second.
Okay. That makes sense.
So is that why, is that an example of when the primary wouldn't be the same as the principal on the UB?
Following your example, which I am in no means an ICD-10 coding expert, as I'm sure you know by now, with all the questions, and all the discussions that we've had. Following all of what you just said, then yes, that could be potentially an example of where
Could
there might be
potentially be.
discordance. But again, the main thing that I just want to make sure is clear is that regardless of that discordance, the payment will be driven by the code that is present on the MDS, which will then feed into their clinical category, which will then feed into their HIPS code.
Which could be either one of those codes listed, and I can see where they might choose the one that's going to have, if one over the other would have a better reimbursement attached to it, then I can see where they could.
I'll leave
Pick
that
and
last part of it
choose.
aside. I won't comment on the
Okay.
reimbursement enhancement part of it.
Okay. I'm just saying they could pick or choose which one of those
Yes.
two when you have two required to sum up the
Right.
principal.
Did we get a mic over to this gentleman before, by the way?
John, we got one.
Oh, sure.
I got one right here. Can you just briefly repeat what you said? You had a slide that had a second bullet that has since been updated about the BIMS and how that affected.
Yes, absolutely. So the question was, can I repeat what clarification I had made with regard to one of the slides where there was a piece of information that was inaccurate. The piece of information that was inaccurate was in relation to the BIMS and the staff assessment, and it was the second bullet on that slide, and it stated that if neither the BIMS nor the staff assessment were completed, that ultimately the patient's PDPM classification could not be determined. That is no longer the case. Okay, so what is the case is that if neither the BIMS nor the staff assessment are completed, then the patient is basically deemed as being cognitively intact for the purposes of classification. So they just wouldn't so even if they had a cognitive impairment, that the grouper wouldn't identify that and they wouldn't get credit for that in terms of their classification. No problem. Yeah.
Yeah. A patient is admitted to the hospital because of an acute fracture, and while in the hospital, the patient develops an acute CVA. Then when this patient is transferred to the nursing home, what is the primary diagnosis? What is the category? Because both are equally important, the rehabilitation for the acute fracture and also the rehabilitation for the CVA.
So I'm going to echo something that Jen said earlier, which is that not being at the bedside, I am not going to say what is the primary diagnosis. The primary diagnosis is coded in I-20B, is intended to reflect what is the primary or main reason that person was admitted to your SNF. And so that is a question that, based on all of that information, plus a lot more information that I'm sure that is in that question, that information would have to drive that answer of what is the primary diagnosis.
And the other question is, what makes a condition an acute condition? Because many patients come to nursing homes with 10, 20 different medical problems, and most of those problems might be active. Patient is diabetic, and basically we're trying to bring the blood sugar down. The patient has a hip fracture that needs rehabilitation. Mm-hmm. The patient also had an acute CVA while in the hospital, and the patient has COPD that is being treated with bronchodilators and with corticosteroids. Then many times it's like 6 or 7 18s going on at the same time. Then how do we know what should we code it as an active diagnosis?
Well, you'd be coding all of them as active diagnoses. I mean, so the MDS, all of those things should be captured at some point on the MDS and certainly captured in your documentation. But I think underlying that question, and sorry to repeat the question was that you can have a lot of different things going on with a patient. And so what would you, correct me if I'm wrong, but the question is fundamentally, with all these things that could be going on with a particular patient, how do you identify the primary diagnosis or the one thing you're going to code into I-20B? I think is a fair rephrase or restatement. And I think that the answer, again, is going to lie at the discretion and the considerations of the provider. So you're going to have to look at that patient and decide what is the main reason that this person is here, what is the best thing I can put into this. I mean, to sort of cite back to the old SAT guidance that we would get, if you had multiple answers that were the right one, pick the best one. And so here, if you have multiple diagnoses that you can select from, but you feel like one is there's a lot of things going on, but it's really not the CVA that's driving their care plan. It's really not the diabetes driving their care plan. It's really the fracture, or it's really the what have you. That's the thing that should be coded as the primary diagnosis. But that's something that I don't think that we can answer for any particular patient. I think that's something we have to rely on you guys to answer based on your interactions with the patient and your understanding of their condition.
Okay, John, we have time for one more question.
Hello.
Hi.
A little bit long, sorry. So the scenario would be resident has surgery in a prior hospital stay before the Part A stay. So then after discharge from the hospital, the patient would then get admitted to, say, the SNF next door. From that SNF, patient stays in for a few days, starts to develop pneumonia, gets sent back out to the hospital, being treated for the pneumonia. After being discharged from the hospital, comes to my SNF. And so now the question is going to be, are we able to code that prior surgery? It occurred in the last 30 days, it's documented, and it occurred during the preceding hospital stay prior to the Part A, but it wasn't the stay, it was for the SNF that the patient went to next door. Would I be able to code it in my SNF if it's still an active diagnosis?
So now I have to try and restate this. So the question was,
Sorry.
No, you're good. I think I got this. So the question was, if a person had a condition for which or for a surgery that they received during the prior hospital stay, admitted to a SNF, they then were discharged from the SNF, gone to a different SNF, and went back to the hospital, came back to a new SNF, can the new SNF code the surgery that occurred during the preceding hospital stay or during the initial hospital stay? Is that?
Yes.
Okay, good. The answer is yes. So if that surgery is affecting their care planning and it's something that occurred during especially their qualifying hospital stay, then yes, it is something that can be coded by that subsequent SNF.